Hi, Greg.
So we
You look
have
good,
a
Greg.
80-year-old gentleman with
Okay,
NYHA class
let's
3
go for the
symptoms.
transeptal.
He has a
Okay.
past medical history of hypertension, paroxysmal atrial fibrillation, COPD. He has a remote history of endocarditis and spinal stenosis with chronic back pain issues and a history of DVT. So he has symptoms of orthopnea. He's also been
I
sleeping
need
in
the
a
transeptal
recliner
view.
chair, not
Sorry, one
just
second.
due to orthopnea, but also due to his chronic back pain. On echo, he had normal LV function. He's got severe MR, moderate to severe TR, moderate aortic insufficiency. His right ventricular systolic pressure was 57. He had an angiogram done recently that showed no obstructive disease. His STS predicted surgical
You're low
mortality score for
and
mitral
posterior.
valve
Okay,
repair
I'm
was
gonna check height.
2% and 3% for
Are we
mitral
too
valve
low?
No, I
replacement.
don't think so.
And I have Dr. Fontana here who
If it's
assessed
zero,
him
you
for
can see where
surgical
they
risk,
are.
who can give us some additional
Is that
notes maybe.
tenting there?
Yes, first of all, I was the second surgeon to see the patient. Interestingly, the first surgeon that he saw recommended a robotic mitral valve repair
Good. 4.5.
and
I'm gonna
addressed
go
So
to
several
0.
you
of
know
the
what?
other
I
issues
don't
that
like the
are relevant,
posterior
including his tricuspid valve
location.
disease.
So
And
let me.
doing a minimally invasive
Really?
procedure in the setting
Look
of
how
moderate
posterior
AI
you are.
No, but
can be
I'm saying
challenging.
bicable.
In
Bicable
addition,
seems to
with
be
his
too
pulmonary
low.
hypertension.
Oh,
So I saw him. I felt
Let
he
me see
was
actually
certainly at high
bicable.
risk just based on
no, it's
his
good. It's
echo, and
like low
then and
fossa,
seeing the
right? That's
patient
what you
Yeah,
due to
want, isn't
his
it?
I do, but I
back
actually prefer
issues
sometimes
and
to do.
musculoskeletal
Oh man.
issues. He moves very
Yeah.
slowly. He's quite
So
frail, and his recovery from a big
let me just
operation
take this
I think would be
out.
quite challenging.
I'm
So
going to
I believe that
repuncture again.
his STS scores are underestimating his true risk for the procedure, and I recommended that he undergo MitraClip.
So this is his transthoracic echo, which was done on April 18th. As I said, he has normal EF, and you can see the posterior leaflet prolapse here and a severe MR. Now I'm going to go to Dr. Gabriel, who's going to present the TE images from today. Thank you.
Okay, Gobi.
Gabriel, take over. You done?
Yeah.
Can you hear us, by the way? Yes. So because I can't hear you, you can't hear them. Hi guys, we can't hear each other. Can you hear us? So, but here's the story. We can't hear each other.
Thank you. But we're finished presenting the case and my perspective, and Dr. Gabriel, we're ready for you to present the echo.
Okay, hello, I can hear you guys.
Now
All
I
right.
can hear you. Now we can hear you. Okay.
Okay, very
Now
good.
now I can hear.
Now it's better. We can
Yeah.
actually hear each other.
Yeah.
So that's good.
All right, we're showing here a bicable image on the left and a short axis of the aorta on the right.
So I'm just going to do the transeptal, and then once I'm getting ready, I would like you to show the pathology more in detail
No
to the
problem.
audience.
Sounds
So,
great.
so let's just do the transeptal properly.
Yes,
I'm coming down.
I see you at there. You're in the SVC.
Yeah. And I'm trying to come as posterior as possible.
Still in the thick part of the septum.
Greg, thank you very much.
Thick part of the septum there.
I like that position. And it's quite posterior. Let's just take that.
Okay, do you want to measure a height or?
Yeah.
Okay, so we'll go to 0 degrees and measure the height from the septum to the mitral valve here. Gonna have to advance my probe a little bit. There you go. You saw the puncture site there for a second. Just slides a little bit.
So he's measuring the distance from the puncture site to the valve, and we can see it's about 4.7, which is adequate. This is really good.
Okay, so now we cross at 0 degrees.
So we've advanced the needle and the dilated inside.
Yeah, you didn't have to use Bovi, huh?
No, it just went in very easy.
Yeah, it was a sign that it was a thin part of the septum there, huh?
Yeah. So what's his weight? So we were low on posterior in our puncture. We're going to give 7,000 of heparin. And Gabriel, while I'm getting all the stuff done, I'd like you to show the images of the echo images of the valve.
Sure. Yeah, sounds good. So there, it's immediately available or obvious there what the pathology is, a posterior flail. It looks to be the P2 segment, and it extends pretty laterally. A very anteriorly directed jet there. Again, there it is in 2D. I previously looked to see what his mitral commissural view would be. And it's closer to, well, actually now it's changed, of course, so that looks like a commissural view. Because it's so eccentric, you don't really see kind of where the jet is originating, but now if we kind of X-plane from here, you can show, we'll show our grasping view here, and you see the large Pisa jet underneath in the long axis view. And go to 3D here to show the pathology, which will be easily seen.
Yeah. Next one.
And there you see a large P2 flail with a couple of torn cords there. And a set home here so that instead of having to make that adjustment next time, it automatically goes to this view, the surgeon's view here. And then we can use multi-view. We've done it already. And interrupt me at any point, Saibal, whenever.
No, please carry on.
Yeah,
I'm liking what you're showing. Very nice.
Okay.
It's really
All
good
right.
pathology. What was the pulmonary veins like?
Blunted on both sides.
All right. Directors, can you guys give now fluoro small, echo large, and then our hands. And then we're going to show the pressures. Yes, this is good. So echo should be large on the right screen.
And so if I move this red plane
Yes, that's
laterally,
great.
you
So
can
we
see
can
it in the
just keep
bottom
it
left
full
image.
pressure.
That's kind of where, well, if we go right into the middle of our pathology, I can see it here and there, and I think that's where we're going to target our first clip. Because of the width of the clip, or width of the prolapse, we're thinking an XTW. We have plenty of leaflet on both sides to grasp here. And if you put color here, you can see we're right in the middle of the jet there. I've increased the wall filter so it now you're looking at just the high velocity jet that's anteriorly directed and kind of also across the valve from lateral to medial direction. In addition, in this view, we can actually measure an area, and we did it already, but I'll kind of go through the exercise here. You just kind of go down to the leaflet tips here, and you see kind of an orifice area there to measure during diastole here. Erase that. Erase, measure, continuous trace. And his gradient to start was 7. So we think that for him, it's going to mostly be because of the amount of regurgitation he has, because he has quite a bit big valve. His area measures at 7.6 there.
Hold pressure. Properly.
And I believe
All
that's
right.
it. I've shown everything I want to show.
All right. In the meantime, I've got 2 wires inside. And in 1/1 wire, I advanced a pigtail catheter. Now you're going to see pressures. And you can see the left atrial pressure coming up. Can you have the pressure line on, please? Is the pressure line on? No. Okay, that's good. Yeah, that's okay. It's on. So that's the left atrial pressure. Can you put that onto a 50 scale? Can you make that a 50 scale, please? So you can see that very prominent V wave 56, and the mean left atrial pressure. Can you call that left atrium instead of aorta? So that's the left atrial pressure, which is the mean is 27, with a very prominent V wave. That explains how he is symptomatic, why he's so symptomatic, and a very prominent V wave. Hold pressure now. So we've dilated the femoral vein. And now I'm going to advance so basically I have a pigtail catheter over 1 wire into the left atrium and the second stiff wire in the pulmonary vein through which I'll advance the guide catheter. And based on the anatomy that Gabriel showed, I think we should use XTW, right?
I agree, yeah.
You want to wear a microphone? You can wear a microphone. You can wear a microphone if you want. Okay, good. Then advance it. Advance it slowly. Go advance. Go. We're advancing the guide catheter inside now. Advancing the guide. Go ahead. Go. Perfect.
Yep.
So we're
Good. There you
advancing
can
the
see
guide
the
very
zebra
gently.
stripes. That's a dilator across, and it looks like the tip just of the guide just made
Popped
it
in.
across too. Yep.
So now the guide's in the left atrium, and now we're going to put the stand on. So now we're going to gently pull this thing off. So let me get the aspiration syringe. So we're going to get the dilator and French out. So we're ready to go. The guide's in pretty deep, right?
3 centimeters. Yep.
Okay. Hold this and gently aspirate if I tell you, okay? Gentle aspiration. When you aspirate, like this. Always like that. Up. Gentle, gentle, that's it. Okay, so the dilator is coming out. Pull the wire back. Yeah. Aspirate a little more. Aspirate a little bit. That's it. A bit more gentle. Less than that. That's great. Aspirate a lot out. Good. Hard.
You can see his
And give the
pigtail,
blood back.
pigtail and guide across there.
Okay, good. So we've de-aired the sheath nicely. We're ready to go with the clip. So we have the clip CD clip delivery system ready to go. Can you do short access for me?
Mm-hmm.
Because I need to see how the guide is looking like. So that's a little anteriorly directed. So Colleen's just giving me some flush there. And I'm just going to do that.
So you can see he manipulated it and moved it a little more posteriorly.
Can I see short axis? It's yeah, it's a bit deep inside. So let's bring it back a little bit.
He likes to have it between 1 and 2 centimeters across, 1.5 probably. And that's where he's at.
Okay, that's good.
Maybe 2 now.
And then I'm just going to start steering the clip towards the valve.
And there it is. And we'll go to X-plane and see.
Slower
And it's
drifts down a
steered
little
in.
bit.
And I'm going to gently go RAO. You see the clip coming down? You see
You can
that?
see his anterior there.
And then I'm just going to clock
That's why
it.
you don't see it. There you go. And now you're seeing it right on top.
Little P.
So I think a little bit more M. That looks good. And a little clockwise. That looks really good, right?
A little more M, maybe.
I think if I do M, so I think it's navigated down. I'm actually going to straighten out the guide to give a little bit of less wall hugger. And then I'm just going to, all I'm going to do is open the clip. Okay, can I see where the clip is? Okay. I can bring it down. So I need to clockwise the clip. So I'm orienting the clip nicely in the view, just to making it as perpendicular to the line of coaptation as possible.
Looks
Okay,
great.
let's take this out. Coleman, come on. It, as usual, didn't work. Okay.
You can see the clip arms nice and wide.
Yes, I can see it very nicely. I'm just trying to get this on here.
And once he does that,
Because
he'll
I had
check
to
his
rotate
grippers.
the clip a lot. So I'm just going to take off a little bit of the skin. Okay, now let me see the grippers.
Go ahead. In the top right image, we're going to be focusing. And that was
So
the anterior.
that's anterior. So blue is anterior.
Blue is
Okay,
anterior.
dot is posterior.
Dot is posterior. Perfect.
Okay. I like the orientation very much. You see that?
Yep.
And I want to take a little bit of M off. Right?
And you're gonna want to move more laterally as well, right? Yes.
Let's go a little bit more middle. You see, I want to end up with no medial jet.
You're right.
So how about that? Should I take a little bit more M off?
Just a little bit, tiny amount. There you go.
do you as you advance, do you see your orientation? You may want to clock it just a little bit there.
Yeah.
I agree.
Okay.
I
Especially-
like this position, but you know, I would like to see in true bicom where exactly I am.
Sure. So the advantage of this is you get a true bicom, but what he's asking me to do is go to 2D. So I will begrudgingly leave this good image and go to another one.
All right, so let's do a bicom
There you go.
and put color there.
Uh-huh.
I actually like that very much. Just
Yes.
hold on from there like that and explain that there.
Mm-hmm.
I just want to be in this position.
Mm-hmm.
You see, I think we may have to give a so that I can get a little bit of okay.
Color off.
I'm going to close the clip.
Mhm.
This is the disadvantage of the system that you don't see both the arms well.
Yeah, when you're in MPR, you did. So you see you had a lateral dive there, Saibal,
Yeah,
huh?
yeah, I saw that.
Maybe
I,
let's correct it above the valve, huh?
Yeah, I
Mhm.
just corrected about the valve,
Mm-hmm.
Good.
right?
Mm-hmm.
Come back a little bit.
You're interacting with the valve there. Yeah, you could. Good. Okay.
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 All right. Let's advance.
Can you
a
see
little.
bicom where we went?
Mm-hmm.
I just
Yeah,
gotta
still,
give a little
still a little
bend.
bit of lateral. Yeah.
Mm-hmm.
Looks like you're
I've
kind of
got
caught on the anterior leaflet
Oh,
there,
wow.
right?
Mhm.
Yeah.
okay, so that's a bit of a bummer. So
Seems
we
like
may
once you open the clip, it will release.
just hold it like this.
Yeah, it should be fine if you open.
Hmm.
Yeah, it released it.
So I'm going to try to pull up to see if I can make the valve flatter. So,
Okay.
yeah.
So it's gone very medial.
Uh-huh.
Mhm.
Because it was caught. It still looks like it's caught, huh?
Yeah.
No, I don't like this.
Yeah.
The leaflets are caught, right?
Mhm. Mhm.
Do you want me to invert?
Yeah, just reset.
I think invert, go up to the atrium and
Wow, that's a really weird position.
there you go. Okay, good. All right. He's free. He's above the valve.
Little P.
Okay, so let me close the clip. Want to see the orientation?
Yeah.
So I went a lot medial, right?
Yeah, it's kind of drifted immediately.
Oh, it looks good actually now, right?
Yeah, this isn't
I
bad.
think so. Yeah. You can see the pathology right underneath the clip. So do you want to go back to 2D or you want to try to do it in?
We can try this. Yeah, sure.
Okay. So just.
So I just want to see.
Rotates.
Here it looks like.
Want a little color just to see?
See, the problem is the color is not very good when you do it through.
His pathology is pretty obvious, though, gentlemen, right?
Yeah.
So I don't.
See, in the bicom, I can't see where you are. Yeah.
I'll show you. I'm still making some adjustments here.
Now
There.
put the color on. Okay.
You're right on it.
All right, I'm going to close the clip now completely. And I'm going to slowly dive inside.
Just watch that medial dive.
I'm going to straighten it out a little bit.
I like your location very much.
Looks good.
Okay, so we went down, but it again dived a little bit lateral.
There you go.
There you go. Good correction.
Good position now.
Yep.
Then I'll open the clip.
Looks like his orientation, he should rotate a little bit.
Clockwise.
And now move a little laterally. But maybe as he comes up, he'll be where he needs to be. You're pretty far in there, buddy.
I don't know why it started to move.
Mm-hmm. You think I should take a look at the septum? Could that be any of it, or?
I mean, the leaflets are on.
Mhm.
The question is should we take this position?
You're very much in the middle of the valve, which would put you kind of on the
That's nice.
right. Yeah, like what you said, you want it to be on the right side of the or on the medial
Yeah,
side of the
yeah.
pathology, right?
Can you show me 3D large so that I can?
Sure.
really-
Yes. Uh-huh.
Can you see the orientation better?
Yeah, I will show you. Yep, in a
I
second.
think this will be a good grasp here.
Yeah, this is great.
Yeah.
Yeah.
Because you'll further lateralize whatever is residual.
Okay, so this is
Yeah.
good.
I agree. Yep.
See but the three. All right, so I would like to close the clip here, right?
Mm-hmm.
And both resting nicely.
Hold it like this.
Mhm.
Like this. Hold it like that. Good. I'm just going to pull it up.
Tension.
Then I'm
Good.
going to drop the grippers one by one. And I've got both.
Yep.
And
Well, you can see them quite nicely in there, huh?
okay. So you like it?
Both
we're
grippers
gonna
bouncing
go-
nicely. You got all of it.
Let's just
Very
lock
good.
it early.
So I'm going to lock the clip. And I'm going to slowly and watch LA pressure now, guys. As it starts to come down.
You can see he's pretty much in the middle of the valve. If you look at the bow tie in the bottom left image. What's happening with your V wave?
It's gone down
Significantly.
completely. So let's look at proper color in this thing.
Yes.
It's
Okay.
moving a lot, bouncing a lot. I wonder whether we should recapture the posterior leaflet a little bit better. The LA pressure is down. Let's do color and let's see how it goes.
Yeah, you can see some residual flail, right?
Yeah.
Yeah. Or
Yeah.
prolapse at least, you know. All right. So we'll get out of this and we'll look at a proper color.
Okay, that's good.
Double orifice, of course.
So let's understand where the jets are coming from.
Right. Yeah.
So here, there seems to be a medial jet too.
Right. But at least in this view, they don't look like they go very far into the atrium.
No, I know. I mean,
Right?
should I go more medial a little bit more? Can you explain this?
Yeah, so this is there is a Pisa there, huh?
On the medial side?
On the medial side, yep.
So we need to go more medial then.
Mhm.
Because we want
Yes,
to we want to lateralize the jet.
I understand. Yep. All right, very good. So we'll go back the way we were able to get a good capture.
No, I would actually just do bicom LVOT
Okay.
because I really need to understand
Hmm.
where I'm grasping. Yeah. Yeah, sure. So I've opened up the clip. I'm releasing the tension. I'm seeing how it goes.
I'm gonna close it. You got almost everted.
Yeah, I'm going to go back again to 190 degrees. I'm going to invert away. I think the posterior is caught, right?
Yeah, it looks like it's caught. Give a little anterior guide toward.
Okay, can we see 3D end face where we are? Single plane. Okay, so that's not good. We need to go more posterior, right?
Mhm.
To me, it looks like you're still caught, right? Yeah.
Yeah, it might be caught on the posterior still.
Hmm.
So we have to
Try.
recycle.
There it goes. Nice job.
Okay. So it's also rotated. It's significantly rotated a lot. Let me see where we are.
A little posterior guide toward.
Okay.
Nice.
I think it's a little, it needs to be,
Let me clock a little more.
increase the gain. I don't like one of the sides. You can see, I'm just trying to bring it more lateral. And now it moved more lateral. I don't like that. Let me see where we are. We moved a lot of lateral. So
Pulling a little medial. Mm-hmm.
we're getting caught in chords. Let me see where we are by Bicom LDOT. We can go for the lateral side if it's good. There's no harm in going lateral. Well, actually, we've got it, but we should release it.
I mean, we want it to move medial, right? More
No,
towards the middle
I
of the
think
valve.
this time, if since it's a lateral side, hold it like this, please, for me. I don't mind taking this side.
And then
Yeah,
put
yeah.
one medial to it.
Yeah, yes.
Okay.
So that's also hold it like this, please. Yeah, good. So I'm just going to come.
3 approach anterior.
See I think the anterior is caught somewhere. Let me
Yeah.
see.
Yeah, the way it's behaving.
Is it very lateral?
Yeah.
There's a prolapse there, right?
Mm-hmm.
Yeah, it's still residual.
Huh? What do you think?
There's still residual prolapse laterally, so it's a good spot, but let's just flatten out anterior.
No, I didn't say. What do you think?
I think you still having it's good to go for the prolapse there laterally, but I think the anterior is still interacting with the anterior.
Yes, so I agree with you. So let's try to take it out.
Mhm.
Let's free it. Oh, sorry. Okay, so now it moved medial. See that?
Yeah, you were stuck.
Right? Now I'm not stuck, right?
This actually looks pretty good.
So
This
can
is
we
actually
see-
where you wanted to be, kind of
yeah,
more in
this
the
is
middle.
actually very nice.
I agree.
3D end phase. Hold this, please.
Yeah, I assume it's going to be pretty good orientation here based on what we see there. Looks great.
Yeah, it looks
Yeah,
perfect.
this is really nice, right? Okay, I
And-
like
and
this
again-
position.
Yep.
Yep.
Yeah,
And I think you've isolated no more pathology medially.
yeah, just slight
So
tension.
the question is, should we take more posterior?
It's a very redundant leaflet. I
Just hold it like this.
think it's buried.
The anterior is very nicely caught. The question is, should I get, okay, so let it go. Okay.
You're going to
Should
miss
have let it-
anterior. Yeah, I think you were in a
missed
good
it, yeah.
position. Yes, yeah.
Missed a good position.
You're getting hung up on anterior there, no?
Yeah, reapproach it.
when it dived medial again.
Yes.
Shit. Okay, so let's fluoro. Okay, so let's come out and get more medial.
There's a cord there you can see.
No, now
Yeah,
I
there,
got something
yes.
nicer.
Yeah,
There you
you're
go.
free. Yeah,
Pretty lateral now.
Right.
but you're
Moved
not
a
in
little
that.
free.
Yeah.
There you go.
Okay. I'm just going to go a little bit more medial.
There you go.
I think I should take this.
Yeah, I think you got it there.
There's a different spot now.
Yeah,
Yeah,
this
we're
is more
lateral
lateral.
again.
Because the respirator is moving too much.
You want to go a
Okay.
little tidal volume?
Okay. You lower the tidal volume, please.
Tidal volumes are down.
Okay. Let me see where we are. 3D end phase.
It's not bad.
So I think this is kind of where our original grasp was.
Yes, this is a very good position. Okay. Let's take this. Correct?
Think you want to go slightly more medial?
No. I want to take the lateral part because now I'm going to lateralize it. You know what I'm
Okay.
saying?
Yep.
Stay like this. Nice. So it's really got it.
Yeah, you got both. They're deep in
And so
there.
I'm going to drop it. And I've got the anterior and posterior
Good
in.
bounce. Good bounce.
Now you can see the V waves are very high. And I'm
Lock
going to
it.
start closing the clip. There's a lot of posterior in. See, this time I like it. You see that?
You see it's tighter.
And this time it's less redundant,
I agree. I think this is a better grasp.
Yeah.
right?
Yeah, good
Yeah.
shot right
This
there.
is definitely a better grasp.
Yeah.
Elevation is good.
On the medial side, you have a little bit
Yes.
of prolapse, but
That's right. So let's do the color. So there's a tiny jet laterally,
you don't
and
need
there's a
to
bigger
address
jet medially. So we should take this, correct?
with the plan of putting another
Medial,
clip medial. Yeah.
right?
Fair
That's
enough.
where that eccentric jet is, ideally.
Hmm.
So let's play. You want to do 0 degree and show us something, and then we can show pulmonary veins and everything. So how's everything going on? Can we continue showing this case? Okay, good. So it's actually going quite well. We've deployed one clip, and we're just looking at the pulmonary veins. There's a definite improvement of the pulmonary
100
vein flow,
Great
which is a very good
improvement.
sign.
Yes. Yeah.
Now let's show every step. So let's do 0 degree first.
I'll check a gradient. Sorry.
Oh,
while
check
I'm
a
here.
gradient. He wants to check a gradient, which is very important. So we got grasp 1 leaflets, and we're checking gradients. The gradient high looks a little bit high for me, but I still think we have to put one more clip. And I think if we reduce it with one more clip, the MR
5.
5, wow.
Let's see
He
what it is.
started
Limit.
off. If I remember correctly, his gradient starting was 8.
Yeah.
Let me see.
So do you want to measure the orifices and see what it looks like?
Yeah, that's a really good shot right there. Shows how much
It
posterior
was
you have.
6 before.
Oh, okay.
Yeah.
So I think it's a lot of MR. So I think we
Yeah.
should be okay. You actually can measure the orifice too. That's a good idea. Why don't we measure the orifice? Let's take a 3D picture and see what it looks like before we accept anything. That's a nice 3D picture. There's definitely a lot of leaflet tucked in. Oh, that looks
Yeah,
beautiful.
that looks
You can see that we've lateralized the flail. We just have a medial side. So you can measure the orifices to us. And if you think the orifices are adequate, that's a beautiful picture he's showing with MPR. And he's going to show in the left lower quadrant, he's going to get the orifices. And so he's going to measure the orifices. And by the way, Colleen, that's the mitral valve. Yeah. Problem is Colleen doesn't even know what valve we are working on. Oh my God. You're embarrassing us in front of everybody. So you see the nice orifices, and you can see, interestingly, the lateral. Oh,
This is
the lateral-
correct orientation. Yeah.
So that's
Yeah.
the lateral orifice.
This is the yes, that is the lateral orifice. Yes.
Okay, got it. And
Yeah,
so
yeah,
that's
sorry,
smaller.
yes.
There's 1.68. That's already quite good. And I think the second one will be low. So even though the gradient's 6, I think it's okay to put another
5. Gradient's 5.
5.
Yeah.
It
Yeah.
came down from 8, and I think it's okay
From
to put
6,
another
yeah.
clip. So this is what we discussed, that even though the gradient looks higher, the valve rate is 3.41, so we can actually put
Plus
a clip.
1.68.
So I
yeah.
like it. We lateralized it. We've got a good grasp, a good tissue. We've got a left atrial pressure reduction. And now we are going to deploy the clip. So Colleen, it's all yours. You just, so,
Question is XTW or XT?
yeah,
not
that's right.
not W. I would say there's
Let's go with
it's not a
XT.
huge flail. Yeah, not a
XT.
huge flail. And maybe you
Yeah.
could even say NT, right, guys?
No, I would use an XT.
Okay.
Can you go and show, see? I think we should just use an XT.
Yeah, okay.
Yeah, because it's a valve is becoming a little smaller, and the prolapse is not large. We can just put an XT.
Yeah.
That's what we are planning. But in the meantime, Colleen is going to deploy the clip. So you do it, and she's so she's going to show it. Close the tight, nice and tight. No, no, completely tight. No, more, really more. Okay, good. Now try to open it. Good.
And I'm just showing here. This is where we're gonna have area to clip afterward. Okay.
Good. And then, yep, good. Yep. Next is.
And there's the
yeah,
eccentric jet there. Yep.
press it down. You still get the-
Later on this month.
So we like this view. We go through all these stages. So the gradient is slightly overestimated because of the MR. You correct? And the pulmonary veins have improved now, right?
Yes.
So she's deploying the clip. There's 2 strings, so you're going to just floss it. Good. Next one. Next one. Okay, you can take it out. Good. Very nice. So she's almost. That's very good. So now the next step is once the cords are out, so you to retighten the clip again. Yeah. Okay, that's good. I like that flushes. Right there. And then bring it back into neutral. Very good. So the clip is quite, yeah, good. No, yeah, actually, this is okay. Take this out. So he's going to take the lock out and then open it. Good. Very good. No. Yeah, oh, yeah, sure. Yeah, sure. Good. And that's enough. That's enough. 8 times. 6, 7, 8. Gentle pull back. Very good. Pull these together. And then pull this handle back together. Good. Pull it back. Great. So the clip is deployed. And we should see how the clip is on the lateral side. And, you know, the pressures came down even further. And now you can see, let's see how the color, with the color, whether we should use I think I'm inclining to using an NT, XTW, and keeping it very close.
What's the reason for using that clip?
You see, the clip is quite wide. The jet is quite wide. I think we should do a W.
Okay.
Have you got it? You opened it?
That's an XT. I get you a W.
It's okay then. I mean,
I
You're
got
gonna
a
pull-
W in the room if you want it.
Huh?
I got a W in the room if you want it.
Let me see how the flail is from the fixture onwards.
Did you pull out your
got it.
spear yet or not yet?
Let me do that.
Your
Right.
CDS, yeah. Okay.
We're gonna pull that out. We're gonna
Take
take.
your arm off. See your guide. We have
Yeah.
guide looks good. Yeah.
There's enough guide. So we're coming out. Yep.
Okay.
I mean, we can do an XT if you've.
No,
I just.
you have enough area, and
Yeah.
and now that
let's do an XTW.
Okay.
and now that you released the tension in the system, it does look like a wider
Yeah.
jet,
I was
right?
just making sure. I
Yeah.
remember the anterior leaflet was really tacky. I just want to make sure we don't get caught. That's the only reason. But if you feel comfortable with the XTW, I got it.
Okay, let's get an XTW. Good. So we've got one clip down. We're going to put a second clip, and I think we'll be done once the clip is prepped. That's it.
And that's just medial there that I'm showing.
And so we'll go right medial to that.
Mhm.
I think we have enough orifice area.
Yes.
Our V wave has definitely come down. Go back. Give it back.
You got a post deployment
Give it
gradient, Gobi?
So we found that it's the system is now the mean air pressure is 20. And actually, while you're showing them, I'd like you to show the audience the nice images that you got. Yeah, let's measure the gradient now. I think the gradient's a bit even down. The heart rate is a bit slower now.
Gotcha.
What's the blood pressure?
140.
Gotcha.
So
Yeah, 136. Yeah.
Yeah, so that's great. So the blood pressure is 136. Did we start lower or higher? So the mean gradient is 4 now.
Mhm.
I think it's okay. I think
Yes.
if we put the clip very close to each other, we should be okay.
Yep.
Though the studies show that when people use second clips, they often go with a. If you look at the 3D in this case, can you show the
Can you do me
3D
a favor?
nicely?
1 second. Sorry. Can you make 2 copies of this for me? Sure. And then will you take this the originals to the chart for this patient in CBOU? Yeah. Yeah. And this will go to them too.
Okay.
But 2 copies of that record.
I want you to see how the LA pressure has become nicer.
It's
I want to thank the staff for staying so late for this case. I know you wanted to go skiing, but that's.
It's this one. This is the second one.
I also wanted to mention Kathy. Kathy's one of the nurses here. She's actually monitoring, and then Sophia is over here. She's circulating. So we actually have a lean team during a MitraClip case. People say that there are not 10 doctors. We don't have one. We have actually a first-year residents assisting in a case, right, on MitraClip. And tech. So then we actually want to prove that the MitraClip procedure can really be done by a single person. But the key person in the procedure
Unlock it.
is, of course, the staff, and number
Unlock it.
2 is the person who's doing echo and anesthesia. In our case, we use cardiac anesthesia and echo, and I think
Lock it.
they feel comfortable doing that. Gabe, are you there?
Neutral.
Yes, I'm right here.
Yeah,
Yep,
yes.
yep.
So,
Go to neutral.
do you want to, since we have some time, do you mind
Turn
showing that
open.
3D
Back to
picture
neutral.
Sure.
of the valve
Thumbs
and the residual MR left behind so that people
Both
can see that?
Clippers up and unlock. Go to an
So,
clip.
so basically, that's what it is. You see that there's a residual tear there, so I need to take
Lock it
care of
there.
that flail. So,
Close it all the way.
yeah, yeah.
So I can translate and pull it back.
Yeah, that's a big prolapse segment there.
Yeah, I agree with you. I think when you
Yeah.
had tension in the system, it didn't.
You can really appreciate it now, right?
Yeah.
Yeah. So we should go right up and down in the middle there with
Yeah.
one next to them, and I think it'll be okay.
Nice. You got your XTs all set.
Already.
XTW. I'm sorry.
So our clip is next, ready to go, and so we should be in. Directors, are you okay to continue? We'll finish in about 20-30 minutes. Is that all right? Hey guys, can you hear me? All right. We'll take about 20 minutes. Is that all right? I think. Okay. So we are going quite well. Our speed is, I mean, we've actually done about the first clip, which is the most important to put it in. We've decided to use an XTW, and now we're going to advance the clip inside. Just hold it like that for me, please. And then flush it. No. Pull this back. No, do one thing at a time. Let him flush. Okay. So flush it. No, over here.
Like a waterfall.
No, yeah.
Keep going.
Good. That's enough. Good. Okay. So let me just put the blue to. It's a blue to blue counterclockwise. The catheter. Okay. Good.
Perfect.
All right. So that's the clip inside. You can give me a short axis view, Floro. So you see the clip is coming out. And I'm teaching him, so as I'm advancing the clip out like this, see that's it, that crosses it. You see the double line that means it's straddled. And you can see in the vein over there, it's in this vein. So I start doing M. You can give some M if you want. You could turn it, half a turn.
I got it.
Good.
Yeah.
Bring it down and see what's happening in the clip. Go down more, turn more, right, full turn, quarter. Excellent. And then I just go REO. And usually I use the images to help me go a little bit more. Go down a little bit more. Go, turn down. Excellent. Good.
Thank you.
So you can just go parallel to the other clip. And that's what we like. And then we clockwise it. And we're very close to each other. So you see that? So now we have to be slightly medial to the first clip. So we have to come back. So the coming back means driving it medially. And I'm actually almost there. See that? We're diving just that's the spot we want to be in, right? So
Yeah.
we like that spot. I'm actually going to come away a little bit and then take off a little bit of M to make it look nicer
Very parallel.
as I go in. Okay, so what we can do now at this spot, we can open the clip.
Oh, not bad.
Not
Pretty
bad.
close.
Orientation.
Perfect.
Pretty orientation.
Wow.
Very
So
slow down
just
the
going to
grips a
come
little
back.
bit. Yeah.
We joke it seems to come out 90 degrees every time.
Yeah.
That looks great. That's
So
great
we are orienting
orientation.
the clip by just transmitting the torque.
You can even see your grippers here.
Are you using
Good view.
Yeah, just
fluoro
stay like
or
this.
are you using
I-
fluoro or echo to orient your clip here?
Both.
Yeah,
So there, that's the blue is anterior,
agreed.
dot is posterior.
Beautiful.
Dot is posterior.
All right, so we want to go a little bit more closer.
Mm-hmm.
So we can advance it a little bit in, and counterclockwise it like that, and then turn it like this. I like that position, okay?
Beautiful.
Looks
So let's go to BICOM, LVOT, close the clip. A little bit more posterior over here. I just want
Yeah.
to be very close.
And you can see he's right on top of a prolapse segment
Mhm.
there.
I'm actually going to go more anterior to straighten it
No,
out.
do you see
more
it?
P actually.
More posterior. You see the coaptation point's a little more posterior.
It's a thick
You
bridge.
think so? I don't think so.
Yes. You come up higher and you'll see it.
I did
There's-
it.
You see that? It's you're casting a shadow.
I like that.
Oh, you're squeaking by there. Look
Nice.
good on fluoro.
Beautiful.
A little bit more.
Yeah.
Beautiful.
Okay. And now we should just open the clip.
Beautiful.
Okay. So 3D. So what he's doing is see that he's making me orient the clip, and you see the clip has gone off. So I
I
just
don't know. Are you
counterclockwise-
sure? Are you sure? Hold on. I think you're
I
okay.
think it should go. Yeah,
Yes,
that's
I
great.
think
Yeah,
you're good.
I like this.
Yeah.
You're
You can
Show
also
it again
show
to me.
You can show from this view too. That's below the valve.
No,
This
show
is
me
above.
below the
Yes.
valve.
Uh huh.
Yeah, I like this.
Yep.
Okay. Good.
So back to
And
explain.
Explain that. So definitely don't want to go more.
I think this is the
wait.
spot. This
Yeah,
is the
looks
spot.
good.
Okay, just bring it like this. Just hold it like that. So I meant it more posterior because I want to get more posterior leaflet.
Your steering here was excellent. I mean, this is perfect.
Right?
Mhm.
So like that.
Just hold that tension. You should be good.
I like this position,
A little V.
and I want to cross a V.
Perfect.
Yes.
And can you go and show 3D before I drop the grippers?
Still
looks
looks
great.
great.
A little clockwise, maybe, right?
No, I don't think so.
Okay, so let's pull it up. And then let's drop dot first, and then posterior, anterior.
Mhm.
I like it, and I'm going to start closing the clip.
Lock it early. A little tension back. Good.
Both up and over. Very close to the original clip.
Very parallel.
And the air pressure looks even better. Look at the air pressure. It's dropped even further. It's 17. So this is why we did both the clips. It looks how beautiful this is. And you want to see a color?
So if you were causing stenosis, you'd see an increase in your LA
Exactly.
pressure, right?
So
Yes.
that's the advantage of recording the LA pressure. You can see, and look at that. We just have a small lateral jet, and the medial jet is gone. That's
looks
really a
great.
nice position.
That
It was good
that
to
was
use the
real-
XT,
Really
Yeah.
good.
XCW. Look at that. You can see the LA pressure. I would like people to focus on the LA pressure. The A wave is actually bigger than the V wave. So there's actually no, and there's just a small lateral jet. So this looks very good. Colin, do you want to come here? And you want to deploy it for me, please?
You want a quick gradient?
Okay.
I will.
So let's measure the gradient. Yeah. So I'm just going to adjust the position to see the clip. So yeah, it needs to be closed a little bit more. And look at the pressure tracing. Do you see how the E wave? See the Colin? The E wave is shorter than the A wave. The first wave is the E wave, right? And normally in no MR, E wave is equal or slightly greater than A wave. But
And that's
if you
how it
have
was
severe
originally in this
MR,
patient.
if you have severe MR, the E is always much greater than the A.
Perfect.
But look at how it's good now.
And
And the gradient's
gradients.
5. It stayed the same.
Five pre-deployment. It's great.
So and the LA pressure is 17. We started with 27. So I think we're ready to go. So you want to try tighten it up. So
And look at
rectus-
that. Cybele.
So we have, yeah, and
Yeah.
this is absolutely normal pulmonary veins. Okay, good. Start opening it up. Yeah, yes.
Great
So we
results.
just have 5 more minutes and we are done with this case.
There you
So we
go.
did the whole MitraClip in less than 30 minutes.
Mhm.
Yep.
The cap,
Yes, good.
and just make sure you got a little drip. Just a little
He's
bit.
going to show us a nice 3D picture in the meantime. Okay, good. See that? What's it? So when I was telling you to clockwise the catheter, I was running the catheter posteriorly. When I tell you to counterclockwise the catheter, and you see that? The double orifice valve and both the entire flare is taken care of.
Yep.
So you see the aorta is on the top, and if you extend the view, aorta in the top, the mitral valve in the middle, left side is atrial appendage, right side is septum.
And there's
That's
just the
lateral, medial, this thing.
Yeah. We
Is-
still got
Just a small jet and the commercial jet
Agreed.
there.
Yep.
still nice dual
But the
orifice,
big
right?
jet, yes,
Yeah.
yes, please. Yes, go ahead. So I quickly look at fluoro to make sure it didn't open up. Looks really nice. This is a great result, actually. Okay, now just close the clip, tighten the clip. Very good.
And you can see in
Excellent.
that short axis view in the bottom left, it's
Yes,
just
it looks
they're
beautiful.
both clips are
Okay.
very close to each other.
All right, and you want to, yes, go ahead. Good. No, if you closed it, then you opened it up. No, you should bring it to neutral. Yeah, bring it to neutral. Okay, so don't come to neutral. Last part always has to be neutral. Great. Yep. No, it's okay. This is, yeah. Yeah, that's the last part. Yeah, good. Take this out. And then you start opening this spin 5 times. So you see the thing. Good. Right. Now 8 times. So I think we're ready to deploy. Say
Should be deploying here.
7, 8, and gently pull that back. Very good. Pull that back, and now pull the handle back.
Perfect.
Actually, the handle's already back. Great.
Nice.
So you want to go live now and show us
Sure.
nothing crazy? You see, cine-wise, both the clips are stable. See that? How nice they are. And even fluoroscopically, I just put them very close to each other.
And that medial orifice is 3 centimeters still,
Yep.
and 1.5 still laterally.
So we're ready to get the guide out.
And we're left with trace to mild MR.
Okay. Gently aspirate. Gentle, less than that. One family veins and summary, aspirate. Good. So I want that final LA pressure, please. Give it back. Okay. Give it back. Did you measure that, Colleen? Sorry. Kathy?
Nice images.
Thank
Kathy
you.
measured this one.
Nice guidance.
This is really good. So you got it? Okay, I just wanted to measure another pressure after I take the guide out. You make the guide negative and then pull the guide out. Remember, we have a pressure tracing in the pigtail out and measure that one. This is the final LA pressure after the guide's out as 15. So that's a 2 millimeter drop because of the shunt that causes it. And so you can pull the guide out now. And we're done over here. I'm going to take one more pressure of the right atrial pressure.
And I'm
Measure
looking
that.
at the AST that's caused and making sure it's left to right, and it is.
Call right atrial pressure. Can you call
And
that right
small.
atrial pressure? Kathy? Yes. Yeah, that looks great. The pulmonary veins are normalized. We have just 2 tiny jets. I'm very happy we used 2 XTWs.
Yeah, it was the right
Okay.
call for sure.
That's really good.
Okay, so let's call this out. Hold pressure here.
The final gradient, post deployment.
Oh shoot.
I think it was 5, but I'll double check now that it's deployed.
Okay.
Baseline was 5 2.
6.
So we're you can focus on the groin. I've done 1 figure of 8 stitch. Yeah, I do need one. We just use 1 per close. Can I get some gauze? Can you get one gauze?
4.
And we got a great, really, I mean, this was torrential MR to mild MR, almost trivial. We just got one perclose in the groin, and it thinks like we've got enough hemostasis. And there's just a trickle of blood. So what I'm going to do now is I'm just going to go to figure of 8 stitch in the groin. And then we'll summarize in 2 minutes. Is that you giving me 2 minutes more? You got it. Did you like the case? Yeah, so we actually got a great result, almost perfect. From torrential, we went to trace. I'm just giving a figure of 8 stitch. The family came from out of town, and they were waiting all day to have this procedure done. So they actually want a copy of the whole video recording, and I promised them I'll show the video recording. So I think they'll really be happy to see the live video recording of this procedure. And I think it'll be a great feedback for patients to actually see some of these, hold pressure, to see some of these cases. So I did a figure of 8 stitch in the groin, and there's absolutely no bleeding now. And that's it.
I'll take Sugamadex too, please. Thank
Yes. Oh, you took it off the monitor? So I want to thank everybody in the audience and who's seeing this case, starting with Dr. Gabriel, who's
No
the cardiac
problem.
anesthesiologist and an outstanding imager. We were lucky to have him today. I have Colleen Shell on the right side, Gabe Oreda, Asma, Kathy, Sophia, and I also want to thank Gabe Oreda, and I also want to thank
Pierre.
Pierre. What's your name? Pierre?
Pierre. You call me Piero all the time.
I know.
Okay.
Pierre is from Abbott. We always have a clinical specialist from no matter how experienced we are, it's always good to have someone from the company guiding through the steps, because there are many steps in the procedure. Sometimes things can go wrong. And that's why I think it's very important to be always listening to what they say. And for everybody, I want to tell you something. I've been doing this since 2005, but I still listen to what you guys say. So thank you very much. And thank you, Medstream, and thank you, Samin and Samir, for allowing us to show this case.